It is my great pleasure to introduce our today's speaker, Dr. Usama Hussein. Dr. Hussein is an assistant professor of nephrology within the Department of Medicine at Macon and John Brock, Virginia Health Sciences. He also serves as the president of the Nephrology Associates of Tidewater, director of home dialysis program. Dr. Hussein is a board-certified nephrologist with more than 15 years of clinical, academic, and leadership experience. He completed his medical school at Moscow Medical Academy. He completed his internal residency and nephrology fellowship at Yale University St. Raphael Hospital. He completed his transplant nephrology fellowship at Mayo Clinic. Dr. Hussein at Central Norfolk General plays a vital role in the kidney and pancreas transplant team, participating in more than 100 transplants each year. Dr. Hussein has special interest in peritoneal dialysis and home hemodialysis. He has helped establish innovative home dialysis joint ventures that now serve more than 200 patients across Hampton Roads. He is a passionate clinical educator and very involved in the nephrology fellowship program, as well as in didactics with the medicine residency program. Please join me in giving a warm welcome to Dr. Usama Hussein. He is going to be talking about peritoneal dialysis updates. Thank you, Dr. Hussein.
Thank you. Well, thank you. Can you guys hear me well? Let's see here. Can you hear me? All right. Thank you, Dr. Saad, for the kind invitation. And I'm excited to be here. I do have another passion in my life aside from home dialysis, which is saltwater fishing. I want to just put that out there. So today, what I'm going to try to do is give you really a quick overview of peritoneal dialysis, where we were, where we are, and how the future will look. Touch base on PD essentials, and talk about the new trends in peritoneal dialysis world as well. At the end, I'll leave about 5 to 10 minutes, hopefully, for discussion. I would love to hear your feedback. Would love to hear some questions from the audience and see how we can further collaborate. I had a really fruitful discussion with Dr. Saad on how we can provide as a practice more education, more rotations within our department to get the dialysis exposure more to the residents, medical students, and fellows. This is my disclosure. I'll be using some slides from the Advanced Renal Education Program. This is a website that I highly encourage everyone, medical students, if you want to take a screenshot or scan it. It has valuable information when it comes to dialysis, dialysis prescription, modalities, quizzes. It will also provide you with some calculators, PD calculators, HD calculators, extremely helpful. I would encourage everyone to use it. Nephrologists, a lot of nephrologists are aware of this website, but some are not, and I've been advertising this for the residents and medical students as well. All right, my objectives, as I said, we're going to go over some stats, talk about PD essentials, PD prescription and new trends, non-infectious complications of peritoneal dialysis, and then finally talk about the infectious complications associated with peritoneal dialysis. All right, this might look depressing. The incidence of ESRD between 2002 and 2022 have been really an uptick in ESRD incidence. It's about 33% increase between 2002 and 2022, about 33,000 extra dialysis patients accounted for. But if you look at the slope here in the last few years, if this will cooperate, yeah, you will see that we're almost plateauing between 2019 and 2022. And there are some factors that led to this plateauing with some, or to, I think, what we're going to see actually a downtrend in the near future. A, COVID, B, a lot of excellent dialysis modalities that coming out, and treatment for advanced stages or early stages of CKD that delay the need to start dialysis. So I anticipate that the incidence rate of ESRD in 2023 on is going to be much better than what you see here. All right, we've done tremendous job. If you look at the complications rates associated with peritoneal dialysis, just a historical kind of perspective, PD used to be really scary for nephrologists because of the complications associated. The peritonitis rates in the 80s and 90s was as high as 30%, 40%. So when you tell anyone, any nephrologist back then, okay, I want to use PD for my patient, the first question is why? They're going to end up definitely having peritonitis 1-to-2 ratio of ending up with that. So what I'm trying to show here that we've done tremendous job in reducing those complications, and this is a sum of different reasons, but would focus on peritonitis rates. About 50% reduction down to 3.9 per 100 person years between that 2012 and 2022. All right, we're spending a lot of money. I think everyone knows that ESRD takes up a chunk of the money that CMS spends on the healthcare. I think it's about 8%. It's in the billions of dollars. If you combine how much we spend for IHD, in-center hemodialysis, home hemodialysis, PD, and preemptive transplantation, it's about $50 billion per year. But if you focus on the upper line, you'll see that that's a combination of ESRD. Next to it is in-center hemodialysis. 80 to 85% of patients are on in-center dialysis, which is something that I struggled with all the time. And I will show you why I'm struggling with this in the next few slides. So from a cost perspective, there's no question that peritoneal dialysis is more beneficial to the CMS in terms of money. Peritoneal dialysis average cost is about $38,000 versus in-center $64,000, about 1 time and a half the expense that for PD versus in-center. And then yet, when you look at this diagram, you'll find that the overwhelming majority of patients are doing in-center dialysis. So it begs the question, why is that happening? Why is it? I show you that the complication rates are better. We're doing better in terms of education, in terms of the modalities, in terms of the equipment, in terms of the supplies, but still, that number hasn't really budged. In 2002, we were about 6% PD penetration, and we only doubled that over the span of the past 20 years. Some might say, okay, well, PD is not a good, really, or viable option. Well, I can show you data from around the world. Hong Kong, Singapore, Scandinavian countries, New Zealand are doing tremendous job when it comes to peritoneal dialysis, as high as 70% penetration when it comes to PD. As a matter of fact, some countries like Hong Kong or Singapore, the first option is peritoneal dialysis. So you have, if you have established ESRD diagnoses, you are going to PD unless there is a really good reason why you cannot do it, or a medical contraindication, or if you want to pay out of pocket. Where, as you see here, the United States used to be actually a lot worse than what we have here. We're in the middle. We used to be at the bottom because the rate was less than 6% up until recently. All right, so why peritoneal dialysis rates remain low in the USA? Many factors, but I'm going to focus on 2. And to me, those are the most important ones. Number 1, provider, physician education bias. You might not know that about 30% of the nephrology programs in the United States do not provide any exposure to home dialysis. So if the physician or the nephrologist doesn't know much about peritoneal dialysis prescription or uncomfortable in prescribing PD, it's unlikely that he or she will advocate for peritoneal dialysis. I've had actually some interactions in one of the big meetings for nephrology with some nephrologists that claim that, well, you know what, PD, if you have a patient with PD, he shouldn't be really on dialysis. PD is not a viable option at all. So that tells you the lack of really understanding on PD physiology and PD clearances that we can achieve. The second most important, in my opinion, is the operational infrastructure. The industry and dialysis in the United States is managed by large dialysis providers, DaVita on one hand, and then Fresenius, and then there are some smaller ones below. They make the in-center dialysis so easy. It takes me really a minute to pick up the phone, call and say, this patient needs to go to in-center, and it happens, and the patient is doing dialysis next day in-center. Where it's not the same when you want to send someone to do peritoneal dialysis. There are a lot of things that need to happen before. You need to look at their house situation. You need to look at their financial situation, either transportation, we have to find a surgeon who is willing to put the PD catheter ASAP for you, the post-operative care, all of that. So what I'm trying to say, the system until now is not as smooth as it is for an in-center approach. And then plus other things that are outlined in this graph. But when you ask the patients, really, what modalities you have been offered? There was a survey that was done by Dr. Malhotra in 2005 that just asked a simple question about this specific aspect. And surprisingly, only 34% knew that there's something called peritoneal dialysis. What I'm trying to say, patients do what we tell them. If I am a nephrologist and I don't discuss the options with the patients, there's a very good chance that they will just do whatever you tell them. Actually, I did a survey on a double that number, about 750 patients who are in-center. I was just curious on why they ended up going to in-center versus going home. And I got the same question, simple phrase, my doctor told me so. 70% of the patients said that. And that's changed. We, in our practice at nephrology, I'm very proud to say this, we've done tremendous work over the years. And I'll show you at the very end a slide of our journey and story and how we changed this paradigm in our area. All right, let's shift gear and talk about anatomy. I'm not going to bore you a lot with this, but I think it's essential to understand at least the basics of peritoneal dialysis. You have a naturally built-in filter. The peritoneal membrane serves as a dialysis membrane, your peritoneal cavity as the dialysis compartment, and then your membrane capillaries as blood path. There are four simple mechanisms that allow solute clearance, diffusion and convection or solute drag. And then for the water exchange, we utilize osmosis and fluid absorption. We do have a variety of PD solutions in the United States. I'm going to speak here only about what's available in the United States. There are other solutions that utilize amino acids and other components, but it's essentially boils down to three components: osmotic agent, most of the time glucose or dextrose or icodextrin, which is a larger molecule, and you need a buffer, lactate most of the time, or sodium bicarb, and then electrolytes, calcium, potassium, chloride, and magnesium. Note that there is no potassium in the peritoneal dialysis fluids. Hence, a lot of our patients might require PD, addition of potassium supplementation orally when they do peritoneal dialysis. It's quite the opposite from hemodialysis. When someone is in hemodialysis, we go over low potassium diet every single time we see them. Quite the opposite with PD. We actually encourage them to increase their potassium intake. It's okay to take a banana or an orange every day. We want your potassium to stay up because every time you do a PD, there's significant loss of potassium with each exchange. PD solution options, volume-wise, anywhere between from 1 liter to 6 liters, and from concentration, osmotic concentration, 2 classes, glucose or dextrose-based and icodextrin. And for the osmotic concentrations, for the glucose, when you order it in Epicures, for example, you have the choice between 1.5%, 2.5%, and 4.25%. The higher the concentration, the stronger the osmotic drag, the more clearance you might get, the more ultrafiltration you'll have. The icodextrin is a large molecule that allows for the PD fluid to stay there for a long time without having reabsorption. The dilemma that we face sometimes when using the dextrose-based solutions or the glucose, that there's a chance of reabsorption if they keep the fluids beyond the equilibration point for these solutions. And every patient is different. We test something called peritoneal equilibration test to find out their membrane character and transport, fast, average, high, low, etc. And based on what we learn after we perform that test, we choose the type of solution that we want. 3 simple phases of peritoneal dialysis: fill, dwell, and drain. Fill is about 10 minutes. Dwelling, depending on the modality that you're using, it can be anywhere between an hour and a half to 6 hours. If you're using cycle, then it's an hour and a half or 2. If you're using manuals, 4 to 6, sometimes 10 or 12 if you're using icodextrin. Now, how do we come up with the prescription? Anytime I approach my patients and I want to start a prescription, I think about a few things: quality of life, lifestyle, the target for the clearance. I want to incorporate their kidney residual function. I'll talk about that in a minute. And then the ultrafiltration goals. Do I want to really shoot for a specific ultrafiltration goal or try to achieve euvolemia utilizing diuretics? And this is a key aspect in the peritoneal dialysis work. It's unlike hemodialysis, where patients go every time to their treatment and they're expected to get some ultrafiltration. In PD, it's a little different, especially at the beginning. All right, we're going to go over some modalities here quick. This is called standard or generic. Keep this in mind. This used to be the trend 5-6 years ago. Every single patient will have to be wet around the clock. They have to have some peritoneal fluids in their cavity around the clock, 24/7. And if you're utilizing the manual CAPD, you do at least 4 exchanges. That was the standard. Every single patient, irrespective of their kidney residual function, will get that 4 exchanges. And you can mix and match. You can do 3 exchanges during the day and a long dwell during the night. If the patient is working at night, you can flip that. You can customize it however you want. But the basics of this is 4 exchanges, 24/7, wet all the time. Continuous cycling PD. This is just utilizing the cycler. Same idea, same concept. You run a lot of exchanges, shortened times overnight, and then maybe you do a long dwell during the day. There are some hybrids where you can mix and match. You can use cycler and then 2 manual exchanges during the day. What I'm trying to say, there are a lot of flexibilities when you use peritoneal dialysis. But we learned recently that peritoneal dialysis approach that we used to have, the standard 4 exchanges a day, isn't really a good way of doing peritoneal dialysis. And there is a trend now to do what's called incremental PD, i.e. you start slow and low, and then that's frequency and volume, and you cater it to the existing renal kidney function, residual kidney function that the patient has. And there's also the decremental PD. If I inherited someone or I have a patient with standard 4 exchanges a day, and he is doing 4 treatments, and he's wet all the time, and he still has producing urine and has some significant residual kidney function, I tend to decrease that. Instead of 4, I can do 2, watch, repeat the PDA or the adequacy, and customize it accordingly. All right, this is just an example, full versus incremental PD. For the incremental PD, fewer total exchanges. You can think about that. Low volume, instead of standard 30 cc per kg, you can go actually lower. And to keep in mind that you won't really achieve the quality of life. Back in the 90s and 2000s, the main focus was on numbers. You want to achieve a KT over V, which is the crazy number that Nephrology Society came with years ago for achieving the adequate solute clearance, irrespective of the quality of life. So patient will be bloated with 2.5 liters or sometimes 3 liters of solute in their belly walking to make their numbers look good, but they are miserable. They can't breathe. They really had hardly anything to do during the day because they need to run from one exchange to another. So that's where this idea of incremental came back. And it's backed by some publications that I'll show you in a minute. This is a wonderful online PD calculator that we use in our units. It helps our nurses and physicians when they are about to prescribe peritoneal dialysis to understand their baseline and then adjust it according to their needs. So what you do there is their age, gender, height, weight, transport status by performing the peritoneal equilibration test. And then you plug in the residual kidney function. Nowadays, the clearance for a patient on peritoneal dialysis is really a combination of the residual kidney function plus what you get in terms of clearance from the peritoneal dialysis. That's how we are gauged. That's how CMS looks at us. What are we achieving our clearances or not? So it's important to figure that out. And each GFR, each 1 cc of GFR matters. Each 1 cc GFR is equivalent to 0.25 renal clearance. So if someone comes to you with a GFR of 5 or 6, let's say 5, and your target KT over V in the renal ward is 1.7, so multiply 5 by 0.25, you already have 1.25 renal clearance. I know that probably I lost you a little bit, but what I'm trying to say, you already achieve 2/3 of your target with the residual kidney function that you have. So all you need to do is just add another 0.5 kidney dialysis clearance instead of having a full prescription, instead of hammering the patients with 4 exchanges. All right. Clinical outcomes of incremental PD. There isn't robust data, but at least we know for sure it's not harmful. The limited analysis suggests that longer preservation of renal RKF is associated with incremental PD, no increased risk of a mortality, and it does defer the full dose, the need for the full dose by 6 to 19 months. And this is a study that was done in Korea that clearly showed that when utilizing incremental PD, there is a tendency of keeping the patient anuria-free for much longer, up to 120 months, versus the other group who had the standard 4 exchanges or the around-the-clock WIT approach. So we are interested in preserving that RKF. And why it is important to do so? Because every half cc, and that was a well-known published paper back in 2001 by Dr. Bugman, who is an authority in peritoneal dialysis work, showed if you improve the GFR by 0.5, you tend to decrease the relative risk of death by 12%. And you actually decrease the relative risk of death if you maintain or you increase the volume, urine volume, by 250 cc. So it is extremely important when you see someone on the floors with peritoneal dialysis to think about RKF. It's very important for us to maintain that urine volume and to maintain that RKF. So anything that you might want to order, you want to make sure that you kind of think twice before you order, like CTA. I get that question all the time. Is it okay to order CTA in a patient with PD? All right, this patient is ESRD. Why on earth he's on Lasix? Well, because of what I just showed you. Almost every single patient on peritoneal dialysis is on Lasix intentionally right from the get-go, part of the algorithm, part of the protocol that we use. And the idea is, A, we don't target any ultrafiltration goals. So if someone comes in, we don't put them on PD and say, hey, you need to get an ultrafiltration of 1 liter a day. No, there's steps. First step, fluid restriction, salt restriction. Third, utilizing Lasix if you're on 80 milligrams twice a day. And you might see some crazy doses of Lasix, 80, 120, 180 twice a day. It's okay. There's no need to panic. This is intentional. And you can sometimes see combinations of metallosome, high-dose metallosome in certain patients to maintain that urine output, as long as they can tolerate. So please do not order CTA unless really indicated, and then avoid stopping the diuretics unless you go back and say, hey, are you producing urine? If they're producing urine more than 200 cc, they have to stay on that Lasix. All right, let's switch gear and talk about infections. I'm not gonna go over these infections, exit site infection, tunnel infection, and peritonitis. We're gonna focus only on peritonitis, but I wanna say the following. For exit site, you'll find that some of our patients are a little bit annoying. When you go in the room and you try to touch the catheter, they're very defensive. We teach them that. We tell them you are the best one to care for your exit site. If someone is not doing a good job in taking care of this, you can stop them. You can say, hey, please put the mask, shut the fan, close the door, shut the window, wash your hands, put the gloves, and then come take care of my exit site. And I've heard that many complaints from nurses, and I said, listen, we're trying to educate you. We're trying to help you out. I would love for you to come and we can present you with education, whatever you need. We can get you to understand how this works, but we've got to prevent hospital-acquired infections. All right. Peritonitis used to be chaotic until 2022. International Society of Peritoneal Dialysis came up with a good classification, in my opinion, based on cause-specific peritonitis and time-specific and then outcome-specific. When we talk about cause, it could be concomitant event, timing of the insertion of the catheter, and or enteric peritonitis because of perforation or other causes. And then cultures. It can be culture positive and culture negative peritonitis. And the culture negative, there are a few things that can explain that, but we treat the culture negative seriously if the PMNs were significantly elevated their white cell count in their cell count when they present. Time-specific, any peritonitis that patients develop within 30 days of PD catheter insertion is considered PD catheter insertion associated, i.e. surgical procedure-related peritonitis, and we treat it as such, and we try to talk to the surgeon and say, hey, what happened? Was it something that you did? Did you not give the IV antibiotics prophylactically before giving, and yada, yada. Was the dressing not changed timely? We have very specific protocol on how patients go from getting the catheter, before they getting the catheter, and then follow up in the clinic. All that needs to be happening precisely the way we created all our algorithms. And there is the outcome-specific peritonitis. Medical cure, 70% of patients, if you treat them quickly, if you get the antibiotics ASAP, and I'll show you some time arrangement that I would love for you to follow. Refractory, that's when you fail to reduce the white blood cell count in the peritoneal fluid by the third day. And then repeat if you develop the infection with the same pathogen within after 4 weeks. And then if it's within 4 weeks, it's called relapsing and recurrent. I tend to forget all these, so I don't have to remember. It's okay, but that's something is important for us when we go back to do root cause analysis for our clinics. You don't have to remember it. All right, I don't need to tell you that peritonitis is really bad. It has really negative outcomes. It's the single leading cause of losing patients to in-center or abandoning dialysis altogether. It's the most common cause of removing the catheter. And we've got to do much better in terms of the peritonitis prevention and then treatment. So let's talk about diagnosing peritonitis. Very simple. If you have 2 out of these, abdominal pain and or cloudy fluid plus cell count more than 100, it used to be 250 and then they drop it to 200 and then now it's 200, it's now 100. You have only 100 WBCs with majority left shift neutrophils, PMNs. That's peritonitis. Until proven otherwise, you need to start treatment ASAP. We don't wait for cultures. We treat immediately. If you have someone with abdominal pain and cloudy fluid, and there's no nurse around you to obtain that peritoneal fluid, because that's a dilemma we face all the time. In the emergency rooms, there isn't that nurse who knows how to do peritoneal dialysis, and we have to wait 4, 5, 6 hours before they come. Start the antibiotics right away and save that catheter and salvage it. And I'll show you why time is important in a minute. We use blood culture bottles to collect because the yield is much higher. We do the gram stain, especially when we suspect some fungus, but that's actually common practice. We do it standard for everyone: culture, gram stain, and identification and sensitivities. Now, not all that is cloudy is peritonitis. And you need to keep that in mind. Presentation, history is very important. We just go back to the basics of medicine. But this is just an example on where you can go wrong. If you've done the antibiotics, if you've done the collection of the sample and the cloudy effluent is non-cellular or acellular, this is a differential. Lots of fibrin, which is very rare. Triglycerides, it can give you milky appearance. It can be confusing, but for expert eyes, it's easily differentiated. And then calcium channel blockers, there are some reports suggesting that it can happen with the CCB, lymphatic obstruction, acute pancreatitis. When it comes to cellular causes, obviously peritonitis number 1, eosinophilic peritonitis can happen. Certain patients might develop reaction to the PD solutions, namely icodextrin. It's not unusual to see that. Monocytes and macrophages, so you do your cell count is 900 or 1,000 and it's predominantly monocyte, something is wrong. Most likely it's an error in the collection of the sample. If you collected the sample from a dry abdomen or from a very long dwell, more than likely you will have the monocytes or macrophage predominant specimen. And red blood cells, hemoperitoneume, we'll talk about that in a minute. All right, so considerations. I want to just focus here. If you have someone come into the emergency room with suspected peritonitis, 9 out of 10 the times you'll find that the patient is carrying his bag because that's what we instruct him to do. We want him to save time. We don't want him to wait until they come to emergency room and try to find a nurse who can do a quick exchange. But if in the rare case when they come in and they don't have their bag, you want to make sure you don't obtain the sample from a dry abdomen. You need to dwell for 2 hours and then obtain the sample. That's going to be a very important point. out of this here. All right, so how do we treat? Empiric treatment, very important. As I said, the idea is we want to get the antibiotics ASAP within 4 hours maximum from presentation if possible. And you have to cover for gram-positive and gram-negative bacteria. The commonly used regimen in our units and across the emergency rooms is vancomycin plus cefepime or vancomycin plus ceftazidime. For the outpatient, we have different protocols for each unit, depending on the sensitivities in each location. All right, principles of peritonitis management. Keep in mind that if the patients have some residual kidney function, got to factor in the clearance of these antibiotics, namely or specifically vancomycin. So someone who is completely anuric might go 5-6 days without needing redosing of vancomycin, but someone with a GFR of 7 or 8 might need it much earlier. So you got to make sure that you ask that question when you administer the antibiotics. And that's typically done by us, by nephrologists, but it's very important that residents and fellows also are aware of this. We dwell the antibiotics for 6 hours. Someone is on CAPD, that's already easy. Someone is on APD or the cycler. We continue the cycler, but we add a manual exchange every day. And the treatment depends on the bacteria. Gram-positive, about 2 weeks, gram-negative, 3 weeks. Fungus, remove the catheter right away. And yada, yada. We have charts for each microorganism that we utilize to guide us through the therapy. And then in 48 hours, typically we get the culture and we cater that antibiotic regimen based on the cultures that we have. We narrow it down as soon as we can. All right. Remember I told you very important to get the antibiotics ASAP. This was a nice study, and it was confirmed by another one, that every hour delay in administering the antibiotics can lead to PD failure by 7%, almost 7%. So we are very interested in getting the antibiotics as soon as possible. Someone, again, with cloudy fluid and abdominal pain, assume this is peritonitis until proven otherwise. Get the antibiotics going. If you can get the IP antibiotics done soon enough, give systemic antibiotics, dose of vancomycin and cefepime or vancomycin and ceftazidime, and then we can wait later until we get the cell count, et cetera. Preferably, you obtain the sample before the antibiotics, obviously, if you can do so. But if you suspect that there will be a lot of delay, I much rather treat and have maybe a sample that is not very accurate, or the cultures. The cell count might not get affected tremendously, but the cultures might not be positive, might be culture negative. Because of the antibiotics that we give it. All right, we use protocols to prevent, yes, sir.
How often do you see negative blood cultures, yet positive peritoneal cultures?
Yeah, that's a great question. Very rarely you see positive blood cultures in peritonitis. And actually extremely rare to develop severe sepsis with peritonitis if it's captured early. Because why? Because peritonitis tend to be very painful. At the earliest stage, the patients will run to the emergency room to get treated. So extremely rare to see positive. If they present with blood culture positive, and there's a huge problem, there's an issue going on, perforated vesicus or something else going on, unlikely to be just simple peritonitis. All right, use of prophylactic antibiotics. All these procedures, patients get prophylactic antibiotics before they get them. Even a simple dental, not cleaning, deep cleaning or extraction, they have to get that antibiotic prophylaxis, a single dose. Prophylactic antifungals, you will see us always ordering nystatin or fluconazole concomitantly with antibiotics, and that's proven strategy to prevent the worst peritonitis that we don't want to ever get, that is fungal peritonitis. So nystatin for the duration of the antibiotics plus 1 week. So 2 weeks of antibiotics, they need to stay on the nystatin or the fluconazole for 3 weeks to prevent that fungal peritonitis. All right, almost there. Non-infectious complications in peritoneal dialysis. I'm going to talk about the really common, there are quite a long list of non-infectious complications. I want to just talk about the ones that you might see in the hospital and then 1 or 2 rare ones because of severity. Inflow restriction, most common cause of this is constipation. And our patients have robust protocol. Most of them are really good at it. We are heavy in using stool softeners and laxatives, Miralax or lactulose. The definition of constipation in our book is different than internal medicine. We want a daily bowel movement, a good daily bowel movement. If it's past 24 hours and you haven't had a bowel movement, it's a problem, and you need to start your stool softeners or laxatives. As you see here, the rectosigmoid is distended. There's almost fecal impaction, and I think it's well visualized. The catheter have shifted, migrated up to the pelvic rim. The right position for the catheter is really down in the pelvic.
Direct it at the screen.
If I what?
If you direct it to the screen.
Oh, is that right? Is it showing? Okay. Anyways, so it's supposed to be really sitting in the pelvic area down here at in the Douglas pouch. Not too low, not too high. Too low can cause pain because of the irritation. Too high might cause outflow problems. So it has to be really in a precise position. So this have shifted because of this. And I know it did because this is before and after we treated the constipation, the catheter went back to its position that we want it to be. I shall remind you that the catheter is not stitched or attached to anything. It's free floating in the pelvis, okay? So it's very important to keep that bowel movement coming and then to prevent constipation. All right, two-way flow obstruction. We talked about the inflow. Now, all right, you can't put in fluids and you cannot drain what's happening. And you look at you do the KUB, there's no constipation. What is the differential? Most likely the catheter is now in a good position. This is most likely luminal obstruction by fibrin. And we do see this every now and then. It's like a worm-like nasty thing on the right side that will have to be milked out, really forced out by the surgeons to get the catheter patency established. It's a relatively simple procedure in good hands, and we can resume peritoneal dialysis same day. But we don't see this nowadays quite often because we have protocols to start heparin for these patients as soon as they start getting any signs of microfibrins in the effluent. And they're educated on how to detect that and how to report that back to us in order to address it as soon as possible. All right, hemiperitoneum, panic sometimes in the patients, especially in females, but this is quite common, especially in the female premenopausal. Up to 57% will have that because of the retrograde menstruation. Nothing to be panicking about. 1 cc can turn your entire bag pink. 2 or 3 cc can really make it red. We don't really, I don't want to say we don't get scared until we start to see clots or pain. Typically, this is painless. And the management of this is really straightforward. You do quick exchanges. And then if the patient is menstruating, you kind of refer him to the GYN and try to have him start on contraceptives if it's possible. If they are on anticoagulation, then we suggest that they stop anticoagulation if it is possible, unless there is strong indication for it. So quick exchanges, sometimes we ask them to cool the dialysate to induce vasoconstriction, and add heparin if there are any clots to dissolve that to maintain the patency of the catheter. All right, hernias, very common. The annual rate is about 10 to 15% in PD patients, and the risk is cumulative. Every year they stay on PD, the risk goes up by about 20%. So commonly seen in peritoneal dialysis patients, especially if they're not in good shape, if they're malnourished and their abdominal wall is really in bad shape. The treatment for this is mesh hernia repair, always utilizing the mesh. It's not simple hernia repair without a mesh. You've got to ask the surgeons to do it. And here at EVMS, they've been really wonderful in helping us doing that. So the recurrence rate in our center is very low when it's done properly. All right, genital edema in peritoneal dialysis. You'll be surprised how important this for men. I would not get a call about MI in my PD patient, but if this happens in a male, I sure enough will get that phone call. So it triggers so much panic because it can happen sudden. All of a sudden you have a huge scrotal edema and penile edema, and the patient is frantic and goes to the emergency room for it. It's not uncommon actually, because the patent process vaginalis is up to 40% in men. The good thing, though, in good hands, when your surgeons are experienced, they tend to look for this before they put the catheter, and they fix it. So our rates of genital edema have been really low in our area, unlike some other regions in the country where they don't have the expertise, or they might insert the catheter under fluoroscopy. In our area here, we're strictly laparoscopic PD catheter insertion. We don't do any fluoroscopic insertion. Not to say that it's bad, but it's, in my opinion, it's much better, and the primary function of the catheter is much higher. What do we do about these? Bed rest, elevation of the scrotum, conservative management most of the time will resolve it, and switching patients from CAPD. You don't want them to have fluid by gravity standing up. You do dialysis at night, reduce the volume, reduce the intra-abdominal pressure, and that most of the time will take care of the problem. All right, finally, the encapsulating peritoneal sclerosis. This is the worst complication associated with peritoneal dialysis. I co-authored a paper back in 2011 when I was a fellow with my co-fellow, Dr. Guy O'Malley, on this. We looked into this and kind of evaluating what's the rate and the CT scan findings. So this is a really scary complication that you don't want to see, but I should say extremely rare. Since my graduation from my fellowship, I've seen only one proven case of EPS, and I've treated hundreds of, if not thousands of patients with peritoneal dialysis. So the rate is not huge. It is higher, obviously, in countries who are heavy on PD, Singapore, New Zealand. There's very good database on this, but not here in the United States. The incidence is 2.1 to 19, depending on what paper you read. Mortality rate can be up to 70%. What happens is really severe thickening of the peritoneal membrane and cocooning. Literally, you open up and then that's the reports from the surgeons when I was doing my fellowship. You open the abdomen, you can't really get to anything. It's just one block, complete one block. It's extremely kind of, there are some pictures that I wanted to, but I think they were gross, so I didn't want to show it. The treatment is just, before the treatment, the idea or the pathogenesis of EPS theories that there's a two-factor thing. You have the predisposing factor and initiating factor. Predisposing damage or deterioration of PD. If you are on PD vintage more than 5 years, that's one risk factor that was found to be associated with this complication. And or if you had recurrent episodes of peritonitis. And then the initiating factor is inflammation, namely peritonitis itself. Treatment, not many studies to look into this because it's a relatively rare, steroids or tamoxifen, and surgical removal. If you read the Japanese literature, for example, they describe 8 to 12 hours sessions to peel these for multiple days to try to peel that very thick peritoneal membrane. All right, this is, I think, the one before my last slide. I want to share with you our good story. At Nephrology Associates of Tidewater, we've done really tremendous work with my colleagues at my physicians, nurses, the entire practice in collaboration with Fresenius. As you can see here, we started with less than 35 patients on home dialysis in 2016, and we were able to bring it up all the way to 200 plus. And if you compare our penetration rate versus the national rate, we are at 23%, 23.5% versus 13.8%. Just, I want to just, again, can't emphasize how grateful I am to my colleagues and nurses and everyone who was involved. I tried to upload a picture where we have about 50 nurses who worked in various units, but it didn't work for some reason. All right, finally, I would like to thank EVMS surgery, Dr. Burgess and Dr. Mardiak. They've been really good to us. Flexibility, putting the catheters on time. We've done about 525 cases between 2016 and 2023, and we're still doing a lot more. But this number here is because we've created a database with the collaboration of EVMS, and we're going to start to hopefully get some papers out. The first abstract has been submitted last week, and we're looking forward to acceptance. And with that, I conclude. I'm happy to answer any questions.
Thank you. That was a great talk. So for the in-person audience, please just a reminder, if you're going to ask a question, press and hold the red microphone in front of you. Dr. King?
That was a wonderful talk. Thank you. Just two, I think they're quick questions. For the prophylactic antibiotics before colonoscopy, it's oral and peritoneal. Is that the only instance when prophylactically you're doing intraperitoneal
It's
antibiotics?
actually a single dose of cefazolin 1 hour before.
Before colonoscopy?
Right.
Okay.
Yep. And most of the GI, our nurses communicate that to the GI suites before they go under. And we ask that they give that one. And we have alternative if they have allergies.
Okay.
Yes, it's 1 gram of cefazolin for dental procedures, 1 gram of amoxicillin,
Okay.
1 hour before.
Gotcha. And for inpatient, if I had said I had to, if they're inpatient and they are not appearing septic, it says you can use intraperitoneal antibiotics instead of IV unless there's going to be a reasonable delay. So how much is a reasonable delay, I guess?
Sure. So we want the antibiotics to go in within 4 hours from presentation. If you think that there will be anything beyond that, give the IV antibiotics. And the preferred way of administering the antibiotics is intraperitoneal. If you can get it intraperitoneally because you have much higher MICs. And also clinically much better for the patients because their symptoms subside dramatically. It's amazing when patients come in with 10 out of 10 pain and you put the antibiotics there. Within 2 hours, you come and visit and you can actually do full examination for these patients, unless they have been suffering from this for a few days. If it's an early peritonitis, the response is prompt typically. And that's actually one of the differential diagnoses. If they don't get better with the antibiotics within hours, think about something else going on, pancreatitis, something else. Yeah.
Dr. Tahan.
Yeah.
Great talk. In terms of contrast, how should we negotiate that and go about it if we think somebody needs contrast and we're worried about residual kidney function?
So it's like any other procedure you order. If it's a life-saving procedure, obviously it goes without saying you proceed with the contrast if you have an alternative. Because nowadays we have GAD-safe MRIs that you can use in dialysis patients that have very low risk of nephrogenic skin sclerosis. It's called Duotone, and it's now common practice in all hospitals. Now we use that. So if you want, use that or ultrasound. But if you can't and you really want to do a CTA, then you just have to do it. What I'm trying to avoid is to make it okay to order CTA for patients with PDA. Please remember the RKF. And actually, you'll be seeing more information, more data, I think, coming in the future about the importance of RKF in hemodialysis as well. So it's going to be also important to ask them whether you're still making urine or not if you are on hemodialysis. And that incremental PD, there are some data suggesting that incremental HD might be something that we might want to look into. Now, mucomist has been long gone. Yeah.
Dr. Flimmer.
Yes.
Thank you very much for that talk. It taught me a lot. There's been a lot of interest in aquaporin polymorphisms in the peritoneal membrane. Some people ultrafilter very well and some people do poorly. I believe icodextrins, you don't need an aquaporin to get ultrafiltration, and they're much better for residual renal function.
Right.
Is this your philosophy?
I can tell you this from UK. The reason I asked that question is because a lot of data come in from UK on the icodextrin, and they're big on using some prescriptions where they utilize a single exchange of icodextrin per day. To me, this is really debatable. Does it have to do with the polymorphism? I'm not quite sure, but there's no question that you can get more ultrafiltration for the right person when you use the icodextrin, namely if they are high transporters. What high transporter translates to is the following. If you compare to one who is low transporter, you use the same exact solution, 2.5%. You expect to get ultrafiltration in 4 hours, let's say 500 cc from the low transporter. From the high transporter, you'll get less because they absorb back much faster. So in that circumstance, yes, icodextrin might make sense. Yeah. Yes.
Dr. Bernie.
If someone is anuric does it matter about giving contrast? Does it matter about using non-steroidals? Because kidney function is gone. Is there any prohibition to either of those?
Oh, well, theoretically, no. I mean, if the patient is anuric, the kidney is gone. And we know if it's completely atrophic or for whatever reason he has bilateral nephrectomies, let's say, we don't worry about the contrast and the effect on the kidneys. And the answer is similar, but you might have some other side effects related to non-renal. Yeah.
One other question. Has there been any data or investigation about just administering intraperitoneal antibiotics under ultrasound guidance or prior to having someone come in and administer it through a PD catheter?
Well, that's a fascinating question.
You know, that presumably,
ER
ER
to
docs
get the antibiotics
and
right away.
do peritoneal.
Yeah.
They thank you that.
Yeah,
And
get
so
it faster.
So what's the difference?
What's the difference? Well, I mean, there are some side effects. I would imagine there is a chance of perforation, right? You can get into it, even if you're using ultrasound. Got to be really, really, really good at it, because PD patients might have some adhesions. You might think that you are inside the peritoneal cavity, where in fact you went through and through. So I'm not sure. I mean, I would much rather streamline the process in our EDs, educate them, have maybe a set there available, transfer set is available, antibiotics available to get things going right away. Because I'm sure all of you have noticed that there has been really high a pickup in the number of peritoneal dialysis in our hospitals here. And that's going to continue because we made it our mission in our practice to increase that penetration of home dialysis. But it's a great question. I really didn't come across anything in the literature about that. Yeah, but in doubt, use IV. Yeah.
Dr. Rust.
Yeah, I just wanted to chime in as a comment because I'm at Norfolk General all the time. And so every hospital is different how they handle this. And so what Dr. Hussein is saying is we want to get the antibiotics to them quickly, which means you want the sample quickly. So the first person who should be called is the nephrologist. We should be involved early. This is not the person to say, oh, we'll call him in the morning. And we have talked to the ER and we've talked to the hospital about this because we'll call the dialysis nurse. We almost always have one around who can go down to the ER, and then we can get a sample in a timely fashion, and then we can go ahead and do intraperitoneal antibiotics. Unfortunately, we still get cases where everything has been done except calling us, where they've had a CAT scan, they've had IV antibiotics given, but nobody's gotten a sample or any of that. So it's just early involvement. We can make phone calls that will make a lot of this stuff happen.
Terrific. I totally agree. And I had a brief discussion with Dr. Saad about more collaboration with the residents, medical students, more education, hopefully, to get these things going and happen timely.
Yeah, well, with this, we will wrap up the grand rounds for today. I think everybody enjoyed the talk and learned a lot. And this is a topic which is, very much of relevance to us as clinicians who are practicing in internal medicine field. Thank you so much, Dr. Hussein, once again, for taking time out for us.